Everybody. Good morning, and thank you everyone for joining us on this sunny Thursday to hear Dr. Zylla, Medical Director of the Cancer Research Center at HealthPartners and Oncologist and Hematologist, present to us today about the use of cannabis in cancer. And so without further ado, Dr. Zylla, thank you for being here, and I will hand it off to you.
All right, great. Thanks, Abby. Thanks for the invitation, and happy to jump into things. As Abby told you, I'm a medical oncologist. Work out of the Health Partners Cancer Center. I'm also the medical director of our Health Partners Cancer Research Center. I'm just going to kind of jump into things. I think there's usually a lot of question and answer things, so feel free to put things in the chat. I've got a lot of slides. I'll go through them fairly quickly. Slide here. Don't have any conflicts of interest. These are the things I want to briefly touch on, and most of it's going to focus on the end section about kind of what we've done at Health Partners and some of our past and current and maybe even future research opportunities. But just to give you all some background in this issue. So it's a key issue, right? We, especially in cancer, I think it's maybe even outside of cancer, have patients who express a lot of interest in knowing about cannabis, but most clinicians just don't feel well prepared to discuss that with them. And so there's a number of questions that come up. You can see here who's using it, why are they using, what are they using, why do they use, what are some of the potential concerns or worries, and then again, what we are doing here at Health Partners. So who's using? Well, a lot of people. It's a green wave, as they say, spreading, and most states now have some law on the books for either at least THC or CBD, and then more and more states, and as we all know, Minnesota is one of them, have now gone to a recreational use state. So I think other than a handful of states, there still are maybe a little bit of holdouts. Minnesota's program is interesting. So it started in 2015. Every year there's been indications that have been added since then. You can see some of the first ones, though, were in cancer. For patients with cancer, they had to have severe or chronic pain with it, nausea or severe vomiting, or cachexia or severe wasting. And many, not all, but many of our patients hit one of those marks at some point in their cancer journey. You can see all the other issues that are listed there. This is somewhat of an outdated slide, though, because when the recreational program launched, all of these still exist as conditions you can certify somebody for, but now there's basically a blanket indication that says you can certify a patient for any condition that you, the clinician, feel that patient can benefit from. So it's essentially an open system for the medical program too. This graph just shows a little bit of the evolution of patient enrollment in the Minnesota State Registry. You can see some big jumps there. Obviously, it took a little bit of a time to get off. Most of the big inflection points happened with different terminology of pain. So they actually didn't add chronic pain to the system until 2020, and you can see then that allowed more patients to be certified. And then another big jump happened really when whole flower was added. For the longest time, we'll talk about products. You really only had extraction products, pills and vapes and different things. And the cost of those products was much higher. Whole flower lowered the cost, became more accessible, I think, for many patients, and you've seen ongoing growth since. It's just a little bit about how many new versus returning patients. You can see it's, fairly significant. Each year there continues to be 15, 20,000 new patients being certified. These are up to this point in the medical program, the reasons, and you can see most of it's chronic pain now. PTSD is actually a close number 2, and cancer, actually just a little 5% blip of patients, despite how many people have cancer and all these symptoms that I just talked about. In the cancer population, not surprisingly, it's a little bit older population. So about 75% of patients enrolled in the medical cannabis program are over age 50. That's much different than the other indications or other conditions where it's generally a younger cohort of patients. This is a really, really commonly cited article in Cancer. So patients in cancer centers, what is the prevalence of use in even by different age groups? And you can see on the bottom right, it's about 1 in 4. 1 in 4 patients say they're actively using cannabis if they have a cancer diagnosis. A little bit less as you get over age 70, but definitely there. We did similar studies. We did a very statewide survey with the University of Minnesota a year or two ago now, and pretty good response rates. And we sort of showed the same thing. About 20% report using cannabis since their cancer diagnosis. You can see it kind of spans different cancers, different stages, again, different ages, things like that. So definitely kind of fits with what was known out there. Who's guiding patients? Again, this is one of the big cruxes of the problem. Busy slide, but on the left side, you can see the left side is really just patients who were surveyed in the same article saying how interested they were in learning more about cannabis. And the vast majority, 70%, are interested in learning about cannabis. They also state that most of them want that information to come from their cancer team. That's sort of the figure on the right. But they're not getting it. Only about 10% of patients say that their cancer team actually tells them about cannabis. Most are getting it from their friends, their family, the internet. Probably not the best way to do things, but that's just the way it's been. Again, back to one of our surveys, a statewide survey, we found 72% of patients were comfortable discussing cannabis with their provider. I think that's actually changed quite a bit over the 10 years that I've seen this doing. We had essentially no conversations about cannabis prior to the medical cannabis program being in place, and now obviously much more at least awareness of it and comfort with it. But they really aren't having those discussions most of the time. So again, they may be interested, but they're just not having those discussions. And I think, again, this is a different survey done across oncologists across the country, sort of surveying their understanding and willingness to kind of have those conversations. You can see they claim, now I don't know if this is true, but they say that they've discussed this with patients in general at some point, probably. Some have even said they've recommended it, but they're recommending it, and only 30% of oncologists feel that they have knowledge to make any kind of guidance on it. So last slide about sort of metrics and providers. I was able to figure out we have about 24,000 Minnesota healthcare providers. I think there's APCs, MDs, or clinicians. Only 10%, so about 2,400, 10% or so of those are registered to be in the medical, are registered with the medical program to be able to certify a patient to get cannabis. So odds are 90% that your doctor that you're seeing is not one of those. I think most of our oncologists at HealthPartners are certifying patients, so that we'd be probably closer to the 80-90%, I would think, of our providers. I know a lot of the hospice and palliative care, at least the palliative care doctors are certified or registered, to certify patients. Briefly, this is a little tricky, but what products are available? And sort of this is the hard part, right, of doing this work and this research and even the clinical guidance is what is cannabis and how do we dose it? And it really comes down a lot to like the THC. A lot of people talk about THC in an average joint. So those who may be, old school, it's like, well, how much THC was in an average joint? Well, it's actually changed over the years too. If you talk about street cannabis or sort of open market cannabis, probably in the distant past, it was more, 7-8%, in terms of a percentage of the cannabis plant that had THC. Now those strains are becoming more and more potent, as you can see, probably 15-16%, almost double that over time. You can do some math and basically say, well, if you have the weight of the joint and the percent strain, you can figure out how much THC is in that joint, right? And if it's a higher percent strain, well, then there's more milligrams per joint. And we talk about milligrams because that's what we're used to in medicine and dosing and opioids and pain meds. And, we need to know the dose, right? So that's kind of how you could get to the dose. This is a slide I put together in a review article I wrote, and I'm going to kind of go through it section by section about what is cannabis, right? Well, it's not just one thing, it's multiple things. It's probably hundreds, if not thousands of different products, but it comes down to usually still THC and CBD. THC being the sort of red or sort of the dominant things here. There are some THC prescription medications, right? So Marinol or dronabinol, nabilone, very not commonly used. A, they're expensive. B, they weren't really that effective. And I think a big part of them being not effective is that they're synthetic THC and they have no balancing effect of the rest of the plant, the CBD, the other things that are part of the plant. There are, interestingly, CBD dominant prescription medications. Well, there's one product, and that's called Epidiolex. And that is a very potent CBD product for kids with seizure disorders. So it's an approved FDA product that you can access and use. So it has medical benefit. There is a product not available in the US, but in Canada and other places called Sativex or nabiximols that is an oral spray. It's a one-to-one balanced product. Again, we did a study I'll touch on later about that with that product many years ago. Most of what the state programs and medical programs have, and even things you can now buy on grocery stores and other places, are extraction products. So these are, again, the cannabis is taken out. You kind of figure out what percent it is, or the milligram even. And as I was mentioning with the state program, a lot of that was extraction products, and you can then just decide how much of one or the other that you want. Can come in various routes, things like that. And then of course there's whole plant. So that's cannabis. That's the joints. That's the things people used to use, and kind of what people typically think of as street cannabis. And again, very hard to figure out the dosing ratios we just talked about, and not really something that has lots of THC. So as I mentioned, one plant, thousands of medications. This is just one of our our cannabis dispensaries in Minnesota. I think this is Green Goods. Just shows you now. You go to their website. This is what you see. You got to figure out, well, what do you want and how do you pick it? And even if you just pick flower, again, I mentioned flower. These are currently what you can buy for flower, right? And there's all sorts of fancy names and creative names. And I specifically like the Blue Dream one there on the bottom. But you can do the math again to figure out dosing and whatnot, and try to figure out, hey, if I just wanted 5 milligrams of a dose, what's that going to cost me? My math here says it's only a quarter. So you can't buy much for a quarter these days. But if you buy whole flower and use a tiny puff of it, I guess you could get a 5 milligram dose for just a quarter. So there you go. Most of our patients, though, are buying these extracted products. You can see the cost on the right for a bottle of 30 tablets. Usually it's about $30. The vapes are a bit more expensive. And so again, medical products probably are twice the cost of the whole flower, but are generally what our patients are wanting to just ease of use and ease of dosing and things like that. So again, it's a complicated field because there's so many different products out there. And that's also what makes it hard to, again, provide clinical guidance. It makes it hard to do research in this space, but we continue that effort. So why do patients use? Well, mostly symptoms, at least again in the medical space. This is the review article we wrote many years ago, just kind of summarizing what had been done up to that point. You can see pain, nausea, vomiting, anorexia, cachexia, but also just global symptoms. And I will state many patients we see in our cannabis clinic now, sleep is a big issue. And that's partly because of pain, anxiety, steroids. We give patients a lot of steroids for their nausea. They just can't sleep with them. So I think that's another big one of those more global symptoms that kind of get roped into. But there have been some good studies. We've done some of those studies. The one on the bottom is actually our study from 2018. One of the first things we did, which was a study with the state program. So I worked with the state leaders. We looked at symptom changes over time in patients who got into the program. How this worked is that there was data collected when you started cannabis in the state program. You have to fill out a survey of your symptoms and grade those surveys, the symptoms on 1 to 10. And then every time you purchase a new product, you have to fill out another survey of your symptoms. And so there was some longitudinal data, and you can see here on some of those things, these are just for patients with cancer, those shifts from those higher scores to more of a lower or at least moderate scores in many symptoms. And those are all fairly statistically significant changes. I will note, though, that there's some bias in that, and I'm not going to get into that today, but again, these are only patients who continue to purchase. The patients who didn't purchase or maybe didn't have benefit aren't included in these graphs. So there's a little bit of, you kind of have to take that with a grain of salt. But there's similar data in other places. There's some really good research going on in Israel. They've looked at this kind of similar sort of thing, and over a 6-month period have seen pain score shift. They actually also saw opioid use shift, which I think is actually quite intriguing. And we've seen similar data in some of our studies as well. Again, that's a little more intriguing because, again, usually patients who have chronic cancer pain aren't able to come down on their opioids or aren't able to come off down pain medicines. One thing that you hear, may see or read a lot about is this question of, well, patients may use cannabis to treat their cancer. That's a bit of much less of a validated issue, although as surveys again show about 1 in 4 believe that cancer can potentially help treat their cancer. There's books on this. There's this thing called Rick Simpson's oil. There was a Netflix, movie or documentary or something that was done on this whole topic. It's kind of, it's kind of crazy. I mean, there's Facebook groups with thousands and thousands of people in them that sort of talk about this. The problem is there really is no data. There's no clinical data. There's lab data, animal data, petri dish data, but really very few clinical data. There gets to be some clinical case reports. This is an example of saying somebody, hey, has lung cancer. It's biopsy proven. You can see their scans on the left. This patient declined any chemo or radiation or surgery, and yet started taking CBD, and then the scans on the right show up. So you're kind of like, that's kind of interesting. I'd like to see more cases like that. Well, we actually went looking for those cases a couple of years ago. We combed the literature, said, let's find anything that's been published or out there. And basically what we found 77 reports that were published. Almost all of them were weak. And what I mean by weak is they didn't tell us anything. They didn't really have validating data to support that claim. They didn't tell us exactly what cannabis was used. There just wasn't the evidence to kind of say, for me as a medical oncologist, yeah, you convinced me. You didn't convince me because it was pretty weak what you reported. So I don't know. There's some interest in that. I will say, just from personal experience, I've not seen like dramatic responses in patients' cancer markers or their scans or things like that over the time that we've been treating patients. So I'm not sure that's really the way we should be, guiding patients to use cannabis. Safety, or when do we need to worry about things? Well, safety is a big issue. I will say this: I think cannabis is very safe. I think it's safer than alcohol. I think it's safer than opioids. Really, the risk of overdoses is quite low. You get a little sleepy if you take too much. You start low, you go slow with it. These are the kind of side effects that we generally see, and the ones on the right were the ones we saw in patients in the medical program in Minnesota who are, for specifically getting it for for cancer symptoms. Pretty low rates of side effects, and most of those were fairly minimal. There are some potential interaction. Now, getting back to the medical side of this, we're going to talk about immunotherapy in a minute. Some risk, I think, of certainly patients with schizophrenia, history of that, you have to be careful. Certain cardiovascular issues, again, we're talking probably more heart failure, major hypertension, kind of problems. And there is a potential interaction with warfarin as well. There's anything that kind of goes through with metabolism in the liver, you do have to be somewhat mindful of. But I think generally there's not much interaction with cannabis and most medications. You can use cannabis with opioids. We do it all the time. It's not caused any major issues. This is a sort of general kind of guidance that I like. And again, you can see similar things we just talked about on the left for some contraindications, and then just general precautions that you want to take with people too. The best study was actually the study we participated in with the nabiximols study. It was a placebo-controlled study of dose escalation cannabis. And you can see in that study, the side effects were pretty similar across, what they looked at. And the ones that they specifically were focusing in on for cannabis, yeah, a little more sleepiness, a little more dizziness. Again, most of those are fairly mild. So again, fairly well tolerated drug. I'm going to skip through this fairly quickly, but there is this question about, could cannabis use be a negative thing to do with immunotherapy? And immunotherapy, if you know about it, very, very commonly used drug now. It's very groundbreaking. It's improving outcomes left and right in terms of cancer. But cannabis is sort of an anti-inflammatory drug. It lowers the immune system. That's kind of the opposite of what immunotherapy is trying to do, which is to boost your immune system. So there's some data, and I'm just going to skip through this a little bit, sort of saying, well, maybe those who are using cannabis actually have worse outcomes if they're using immunotherapy. And that's a big problem if that's the case. The problem with some of these first two papers is that it was really poorly done papers. They really didn't account for the fact that the patients who were using cannabis were sicker, had more brain metastasis, had more liver metastasis, and I believe had more opioid use. I'm not sure they actually looked at that though. And so Finally, somebody did a little bit better study where they did it just in patients with lung cancer. They accounted for all these other things, and really they didn't see any major detriment of using cannabis with immunotherapy. We're working on a big study that we have just now analyzed. I'm going to touch on that later. That also kind of supports the same thing, that I don't think it's a big problem, but it's out there and people keep talking about it. So, all right. So that's kind of the quick lay of the land of cannabis and sort of what you might need to know or want to know about it. Let's talk a little bit about what we've done over the years. And so this is sort of my timeline schema, a little bit of a bragging scheme, I guess, if you will. But this is, again, the study I mentioned. I think I saw Alyssa Gavendazon from our research team. She was one of the nurses that helped with this study way back in 2012. She and I are old now. So we were here. This was my first study that I did as a PI at Park Nicollet. Kind of a negative study. We won't focus on that. But it got us grounded in like, hey, this is kind of cool stuff. It's cool to study that we're doing some studies. And then you fast forward a couple more years until the state program launched. And it was right at that time that I essentially started a cannabis working group. And you can see a lot of the players on that list, collaborators over the years. It's still in existence. We basically have met almost monthly for the past 10 years, and really have kind of did the focus of trying to figure out how can we do research, how can we conduct things, how can we create trials maybe through the medical cannabis program, and that's kind of what led to the following sets of articles. And I've mentioned some of these articles already, some surveys that we did, the state paper that we did about all the symptom changes, that was in 2017, a really large article. We then launched, I think the best thing we did was to say we figured out a way to do a clinical trial. And in 2018, we launched our first clinical trial. We called it CAN-CAN, basically looking at patients who had, cancer and had to be on opioids. So anybody with pain and was on opioids, we enrolled them, learned a lot about how to do this kind of work, how to work through the system of the state so that we didn't touch the cannabis, but that we worked with the companies who provided the cannabis to the patients for free, so they could use what they wanted and how they wanted to use it. This is essentially what we did in that trial, why we did the trial. Really, it was a feasibility study. It was small. I think we only enrolled 20 some patients, 30 patients. So, we weren't going to change practice patterns or anything, but we wanted to show that we could do this kind of work. And again, this is how that study was designed, and really kind of how we've designed studies ever since, is kind of doing this randomization, because it is important to have randomization in your studies, to essentially an early cannabis versus a delayed cannabis arm. So in the early cannabis users, they got to use cannabis right out of the gate for 3 months. We tracked their surveys and their outcomes and labs and things like that. And the delayed group was kind of our control group. And so they had to wait 3 months, but then we did give them an opportunity to use it at month 4. So everybody got a chance to use it at that point. So anyway, that's kind of how we designed that study. We've done some other things, some review articles, and then we kind of got realizing probably by 2020, 2021 that like we kind of knew what we were doing, and we said, maybe we should kind of educate patients and create a clinic to kind of provide education. So that's what we did. You can see here, we call it CanCare, Cannabis and Cancer Research and Education Clinic. So not only education, but there's some research components to it. We're collecting data on patients who come into the system with just some simple surveys and kind of long-term surveys. But the real goal is to kind of guide patients, help them understand how to use it, what to use, kind of personalize the dosing plan a little bit. And this is done, I won't maybe go into the details of it, but it's basically run now by my nurse practitioners or my APCs. I've trained now 3 of them to basically do this. They're all virtual visits, so nobody has to come into the clinic to see them. This is also a clinic that is available for anybody, even outside of HealthPartners. So we don't necessarily just see patients, although the vast majority we see are our own patients, but we can see patients from anywhere in the state, as long as they are willing to be certified and use the state program. So again, we had a nice little blurb from Care 11. The link's there. They did a really nice story with one of my patients, actually. If you want to check that out, it's a 5-minute video, but it kind of tells a little bit more about the clinic and kind of the real patient aspect of it. So, and then one of those things, as I mentioned, we're doing is collecting some data about that. We'll touch on that later. For the clinic, kind of current integrations, we have actually just created some dosing guidelines. So the sheet on the left is actually of pretty new document where we just try to typed everything out of kind of how to use it. And on the back end of that is some kind of dosing guidance of like how to slowly titrate up. And as you can see on the right side, this was actually 1 month ago. I was in Colorado, and I think just driving out of Denver, that was the first billboard I saw. So it's a real live billboard. Start low, go slow. Don't overdo it with edibles. Well, that's pretty good advice. It's actually a billboard, I think, put on by the Colorado Public Health Association. So they know what they're doing. They know what they're talking about. That is really the name of the game, is just go really slow, titrate up with the cannabis, and most patients generally will do just fine. So won't go into the details on that. But the clinic's been a good, big success. We've seen, I think we're close to maybe 600 patients since it launched, and really just get lots of really positive feedback from the patients that have that. So a few other studies, won't get into great detail on. You can see that we did there. Fast forward to 2024. Last year was a busy year too. We did another review article on that topic of immune checkpoint inhibition, again, showing that it really didn't seem like it was much of a problem. Most exciting thing, I think, was really late last year. We launched our second big trial called the Pan trial. So now this is the same sort of design, but looking at patients just with pancreatic cancer. And again, same randomization. We've enrolled, I think, about 26 patients from the University of Minnesota and from HealthPartners. So it's kind of a collaborator over there that's helping me with this. We also launched the Cannabis Lab study. So it's a different study where we're literally just doing lab levels of their cannabis in their bloodstream. And so that study just launched. And then I just mentioned this on track, or sort of this sort of new iteration of how we're tracking data in our cannabis clinic. We've created an app. And this is about to launch. It's a study, actually, that's going to go through the IRB. Actually, it was submitted this week to IRB, where we're actually have an app that we've developed to track those symptoms, to log your cannabis use, and for us as researchers then to kind of see what that data looks like over time. And all those same education materials you can see here, kind of like the dosing guidelines for patients, it's all in the apps. So like patients can just go to there and say, hey, I want to know more about that. I want to know more about what HealthPartners is doing in research. It's all there in the app. So we're excited about getting that launched pretty soon and seeing what people think. Another thing we've been working on for a long time, back to the issue of could cannabis treat the cancer, is we have a high dose CBD study that we really are trying to get launched with patients with glioblastoma. It's been a logistical hurdle just with all the barriers of FDAs and approvals for drugs and things like that. But we think we're pretty close to getting that study launched too. So we've done a lot. It's been a busy decade or more, but there are still many, many questions to be answered. There continue to be these hurdles. Probably the biggest are Schedule I. Funding, don't get me started on funding. It's been a big hassle to begin with cannabis space. It sounds like it's going to be even more. And then just this issue, as I mentioned, standardization. How do you do research when there's 1,000 plus products out there? This Buzz Light gear is apparently a very common strain of cannabis on the open market. So that's actually a real thing. 2025 beyond, just some quick updates. So I'm actually part of this Cannabis Advisory Council. You can see the taller guy in the back here. That's me. So that was when the state went to its recreational law. They said we needed an advisory council of experts. So we've been meeting and trying to help figure out how this recreational program's going to be launched. I'm there kind of to provide the medical guidance piece and making sure that there's still this oversight and safe products and the public health awareness and all those kind of things. So we'll see about that. There's been talk for a long time about will the DEA change cannabis to a Schedule III. That will open up research opportunities and break down barriers. So there's a lot going on. Again, this is our mission, like connect, collaborate, communicate, contribute. We have an email address if you want to reach out to us with questions or comments. That's good email to each email, or send if somebody wants a cannabis clinic visit, we can facilitate it through that too. And I think that's kind of it. I know that's a lot of information. Not bad. I think right on time. So I'm going to stop there and open up for questions.
Dr. Zylla, thank you, first of all, for such an excellent presentation, and this is just so interesting. It looks like we do have some questions right off the bat here. Let me get this pulled up. One moment. First question, how can we bridge the gap for doctors to initiate conversations with their patients on cannabis use to manage their symptoms?
Um, how can we bridge the gap? I'm sorry, can you repeat the question one more time?
Oh, yeah, no problem. How can we bridge the gap for doctors to initiate conversations with their patients on cannabis use to manage their symptoms?
You know, I don't have a great answer to that. I think more and more, I guess in oncology, I think we definitely are having those conversations. I think it's the stigma, the barriers have been broken down, and so a lot of times patients are just initiating that, asking us about it. And I think being able to, kind of respond to them. Now, again, we're lucky, I think, in that in our organization, we have a cannabis clinic. And so most of my providers who really probably don't have as much knowledge or interest even in having those discussions. They just say, hey, we've got this great team. They're super well trained. They can talk with you. They can certify you. They can guide you. And so I think they're kind of pushing it that way. But yeah, I mean, I think I talk about it anytime I think about starting patients on opioids. I mean, that's kind of how I've sort of triggered my brain to sort of say, hey, we should probably think about this if I'm thinking about starting an opioid, because I think opioids are no good. I think most patients even are kind of fearful of opioids, and I think they're much more, interested in this issue. The hard part of that, of course, is the cost, right? So cannabis isn't covered by insurance. So to talk about something for a patient and then say, well, you might actually have to pay, $200 a month, $300 a month if you're using lots of it. Like that's a hard conversation to have sometimes.
Thank you so much. And I do have a couple other questions. Second of all, what are the guidelines and perhaps contraindications of cannabis use with type 1 diabetic patients who have cancer?
Guidance with type 1. I don't know that there's any necessarily contraindication to those patients. I mean, some patients with type 1 obviously have a little more risk for cardiac issues and cardiac disease, but I don't think there's a real concern. I wouldn't necessarily dose them or treat them any different than a general patient.
Thank you. And then a third question, may a cancer patient using cannabis drive while using cannabis? Is there a lower level of potency to be able to drive?
Yeah, good question. We do address that like anything. And I think obviously the guidance is to say, you shouldn't drive when you're taking a substance like that. I think the same guidance is given when patients, drink alcohol or take an opioid or do other things. And I think most patients sort of realize after a little while how they feel and how long they may feel on something with cannabis or again opioids. I mean, how many patients of ours are on opioids yet they often drive themselves to appointments and things. They just know, probably not to do it right after they take it, the peak effects. So I don't think that they can't drive, but I think it's a matter of, again, listening to your body and kind of seeing how it's impacting you, how you're functioning.
Thank you. And one question, you had mentioned at the beginning of your presentation how cannabis or medically prescribed cannabis can be beneficial for patients with PTSD. Can you speak more to that? Is it more just like easing the anxiety, or what are some of the effects that you have seen with cannabis use that has helped this population of patients?
Well, I don't generally see those patients. That's not a condition I treat very often. Well, never really. Do I have patients who might have PTSD and cancer and maybe have side effects of cannabis? I'm sorry, symptoms that require cannabis? Yeah, probably, but it's very minimal. So I don't have really experience with treating PTSD.
Thank you so much. Looks like we have another question here. Let's see. Dr. Zylla, what does your ideal world look like when it comes to using cannabis to support cancer patients? What barriers would you remove?
I've never been asked that. It's a great question. I get to like wish list today. I mean, I think as I mentioned, cost. It would be nice to have insurance cover this so that it could be something that we put on the table right away. Back to the cannabis in pancreas cancer trial. That trial we structured differently than our first cannabis trial. That trial specifically for patients with newly diagnosed pancreatic cancer, right? And the whole thought there with the study design is to say these patients have horrible pain, horrible nausea. They're miserable from the time of their diagnosis. And so the question that we had is, well, why not bring cannabis in right away, right? But don't let them titrate up on opioids. Don't let them have this boatload of other medications to treat all these symptoms. Let's bring cannabis in right away and see if that can be the mitigating factor to help them feel better going forward. So, I think we'd love, and we'll see what happens. So far, the study is going really well, and patients have been really happy, who've been on the cannabis. But I think we need data to show that that's a better, option, right? So that if we can get a bigger study and we can show that, hey, if you use cannabis earlier on, patients feel better. Maybe they don't need as much dose reduction of their chemo. Maybe that by default will help them live longer, and they just feel better because they're not on, all this, high dose of opioids. So that's kind of the kind of things that we want to keep doing is work like this. So I think, wish list would be, having cost not be the barrier. For me, again, it's getting rid of some of the regulatory research barriers that are out there that make it hard to do this research, right? We can't touch and control and get a placebo very easily to do cannabis studies because of just the difficulties that are out there. So that, and then of course I as a researcher would love to have funding. It's hard to find funding for a still federally illegal substance. There are pockets of things out there, but I think back to sort of what this group is all here to do is we've been really lucky with the philanthropy that we've had. And most of the cannabis work that we've done, both the prior studies, some of our current studies, and frankly, some of the studies we hope to do in the future have been because of grateful donors and having philanthropy to help us support that, because grants are hard to find.
Thank you. Another question. You mentioned a partnership with the U on one of your studies. Are other healthcare organizations doing this research as well, or is HealthPartners on the cutting edge of this work?
We're the cutting edge. We're the leaders. A couple of times now I've collaborated with the university. It's because they sought us out for, our expertise. So this big survey that the university did, statewide survey, they kind of got the funding for a mechanism that I wasn't able to get that funding anyway. So it was a great partnership. We could do the work and they could, bring me in as kind of a content expert, and that was really successful. Similarly with our cannabis trial, again, great collaborator over there, Dr. Arjun Gupta, who is interested in this space of quality care and improving symptoms, things like that, and just basically said, look, I want to bring some of my research funds to the table too. Let's do some idea. He had some ideas in GI oncology because that's his specialty, and I said, great, let's do it together. And it's been a great partnership. So I think partnerships are incredibly valuable. We have this glioblastoma study. I have a Mayo oncologist, a neuro-oncologist, who's also one of their symptom management experts, who's done some of her own cannabis research. Like, we've been wanting to get this study going for a long time too. And similarly have some partnerships that are starting to brew with others across the country. So it's not just Minnesota anymore. It's kind of beyond the walls of Minnesota, which I think is great, but it doesn't take away the challenges that there is to do the work.
Thank you so much. And Dr. Zylla, if anybody thinks of any questions after the presentation, would it be okay if I emailed you those questions if people have them afterwards? Wonderful. Well, thank you so much for your time and for sharing your expertise and the wonderful, innovative work that you're doing with your partners to help cancer patients with cannabis. And thank you again. I hope everybody has a wonderful day. And Dr. Zylla, thank you for your time.
Richard, thank you, everyone.
Thank you.